Stress. Oh, goodness. Okay. Yes, we are recording if you didn't know. And, we received this funding to really increase our community outreach. So we're really excited that you all are able to join us. We used October as our ADHD and disruptive behaviors talk because October is ADHD Awareness Month. And we can't talk about childhood ADHD treatment without mentioning that this week we lost a giant in the field, Dr. William Pelham. He's really the leader behind how our field really thinks about childhood treatment for ADHD. He was really seminal in the sort of like research around treatment sequencing, and he also developed the summer treatment program, which is what our sort of Camp Baker is based off of. So really Dr. Pelham's work is the foundation of how we do treatment for ADHD at our center, as well as just from an evidence-based lens in general. A few housekeeping things before we jump in. If folks could please keep themselves on mute throughout the presentation. If you have questions, you're welcome to sort of throw them in the chat or write them down somewhere or wait till the end. We are going to leave space for question and answers. We want to make sure we get to all your questions and we get through our content. My name is Dr. Stephanie Sin. I'm the Associate Director of Camp Baker, which is our summer treatment program for kids ages 6 to 12 with ADHD and disruptive behavior disorders. I'm also the Assistant Director of our outpatient center, the Center for Effective Therapy. And my co-presenter is Leah Mace, and she'll quickly introduce herself.
Hi, everybody. Welcome. My name is Leah, and I'm the program coordinator of Camp Baker, which I'll talk more extensively about later. And I'm also a postgraduate fellow at our outpatient center, the Center for Effective Therapy.
Like I mentioned before, please hold your questions to the end. And again, just the nature of this talk is more general information. So unfortunately, we're not going to be able to provide specific recommendations for individual kids, just because we wouldn't be doing our due diligence, providing recommendations without meeting and without fully assessing your kids. But if you are interested in more of that individualized support or assessment, we do offer all the evidence-based therapies that we're going to be talking about today, as well as evidence-based therapies for many different presentations for kids and families through our outpatient center. So please feel free to reach out if you are interested in receiving those services. Our agenda for today. So what we're really going to be talking about is what is ADHD, what are disruptive behavior disorders, what does that look like in our kids, how can that present in schools, at home, what is the scope or sort of the prevalence rates for ADHD and disruptive behavior challenges, and how do those sort of symptoms impair in different areas of kids and families' lives. And if you are concerned or some of the things we talk about today really hit home for you, we'll talk about the types of assessments to be looking for if you are concerned about ADHD or disruptive behavior disorders. We'll talk about the most effective treatments that we know sort of work with helping kids manage these challenges, as well as teaching some skills at the very end that you all can start implementing this afternoon. So we'll sort of round out our talk with some skills that you all can use. So ADHD is one of the most prevalent and impairing childhood mental health disorders that's characterized by difficulties with concentration, paying attention, sitting still, following directions, and impulsive behavior. ADHD is a neurodevelopmental disorder, which means that the brain structure, the way the brain develops, the way the brain works is different in kids with ADHD than their neurotypical peers. Oftentimes when Leah and I are doing sort of like intakes or talking to caregivers, one of the most sort of common things that we hear from caregivers and teachers is that it feels like a choice when kids are acting out, when they're getting up and out of their seats, when they're going to grab some water or having a hard time staying seated for meal times. And we really want to sort of reconceptualize that as a difference in how the brain functions. So kids are not acting this way on purpose, but these are really some of the common deficits associated with ADHD. The concept of ADHD has really shifted over time, and we have 3 different subtypes. So the first we'll talk about is the predominantly inattentive presentation. So these are the kids, this is more sort of present in girls than boys, but these are the kids who might be sort of zoning out in class, making some of those careless mistakes in some of their work, right? Like missing one of the questions on the worksheet or forgetting to flip over the paper to complete the second half. This might look like in schools, kids being really easily distracted, right? If there's sort of side conversations, we're having a really hard time refocusing on our work. We're, sort of distracted by the other conversations going on. We hear from caregivers, oh my gosh, it seems like my kid is tuning me out. They're looking directly at me, but then when we go to, complete whatever task, they're like, wait, what did we talk about? Right? So sort of seeming to sort of tune out, even though they're looking directly at you. These might be the kids who are forgetting things in their daily activities. We need the same things for school every day, and he seems to always forget at least one of them. Right, even though it's the same every single day. Or, oh my goodness, this is our 3rd set of gloves that we had this winter, or the amount of water bottles I've had to purchase for my kid because they keep leaving them all over the place, right? Losing track of their belongings. Those are some of the common challenges for the inattentive presentation. For the hyperactive presentation, this is sort of the more commonly known presentation of kids, right? These are the kids who are, might be constantly fidgeting or moving around in their chairs. They're running and climbing down the hallways or throughout your house. They might be sort of running and climbing all over the furniture and, seem to almost be driven by a motor. These can be kids who, like in schools, are getting in trouble for maybe getting up out of their seats or blurting out answers, forgetting to sort of raise their hand first. And again, a lot of these symptoms that we're talking about between the inattentive and hyperactive presentations, these are common challenges for all kids at some point, but for kids diagnosed with ADHD, these challenges are sort of above and beyond the typical kids their age. So the combined presentation basically means that you're sort of presenting with both the inattentive type as well as the hyperactive type. One of the really sort of common challenges that we see with ADHD are difficulties with executive functioning. So these are our self-regulation skills that we use to accomplish everyday tasks, things as simple as getting dressed to doing homework. Right, so sort of those mental skills that help us with planning, with organizing our time and materials, making decisions, controlling our emotions. So oftentimes we're hearing from caregivers, this is sort of the more clinical language. What we hear sort of most commonly from caregivers is, my kid is a master procrastinator, right? They're good at getting everything else done, but really trying to avoid any tasks that require sustained attention. They might be getting in trouble at school and at home for following parts of the directions, but maybe forgetting other parts of multi-step directions. We're often hearing from caregivers, my kid maybe lacks that persistence. It's really hard for them to sort of power through those tasks that feel challenging to them. They might have difficulties with transitions. And one of the sort of like myths we want to sort of correct right now is that oftentimes parents think, oh my gosh, kids with ADHD can't focus on anything. That's not completely true. Kids with ADHD can actually have really sort of like hyper focus to those preferred interests, right? I bet if you let your kids sort of go for hours doing Roblox or Minecraft or sort of whatever their preferred interests are, right, they're going to be able to stay focused on that. It's those non-preferred activities that can be really challenging. And because ADHD is a neurodevelopmental disorder, a difference sort of in the brain, we expect it to be impacting kids in at least two settings, right? So we need to be seeing these challenges in both like home and school, maybe extracurricular activities. When we are talking about disruptive behavior disorders, we're oftentimes talking about oppositional defiant disorder or ODD. So you're going to hear Leah and I sort of refer to ODD, and this is what we're talking about. ODD is a pattern of defiant and argumentative behavior towards authority figures that can cause impairments in kids' lives, whether that's in one setting or many settings. Kids who are diagnosed with ODD are kids who are losing their temper really often, possibly to sort of seemingly easy task, right? I just tell them to go brush their teeth and we're having a full-on temper tantrum. They might refuse to comply with adult directions right away, or just say like, nope, I'm not doing that. We might be annoying other people on purpose. Again, all kids sort of struggle with these behaviors at a certain point, but the frequency is much higher for kids diagnosed with ODD. To be diagnosed with ODD, this can actually be sometimes confusing for caregivers and teachers because these are kids who can present with very different behaviors in different settings. So sometimes we hear, my kid is really, really struggling at home. He's having temper tantrums every time I'm telling them to do something. She's arguing back with me every time I'm setting a limit. But the teachers are telling me, right, she does such a good job following directions at school. She's able to manage those transitions. Hear the answer, no. And so ODD can be present in one setting and not the other, right? So ODD is not a neurodevelopmental disorder. It is a cluster of behavioral symptoms that we are seeing present at this time. We really describe ODD as a temporary diagnosis if it is addressed early and with evidence-based treatments. So whenever we're providing or giving this diagnosis at our center, we're saying that, by the end of treatment, we have such effective treatments that oftentimes by the end of treatment, your kid is not meeting criteria for ODD anymore. All right. So like I said, ADHD is one of the most prevalent childhood mental health disorders. It is the most common behavioral health referral, diagnosis in special education, and problems in the general ed classroom. It impacts about 10 to 11% of kids, which is over 6 million children in the US. Of those kids diagnosed with ADHD, more than 2/3 have at least one other co-occurring disorder, with about half also meeting criteria for a behavioral disorder, the highest being ODD. Right, so kids can meet criteria for multiple diagnoses, and for ADHD, we know most of the time kids are meeting criteria for another disorder. We know that ADHD really persists. It's a life course disorder, so it persists from childhood to adolescence to adulthood, but that doesn't mean that the symptom presentation doesn't change. As kids get older, the hyperactivity might lessen over time, but teens with ADHD might still have difficulty with those multi-step directions. They may have difficulty making and maintaining some of those friendships. They may be forgetful, disorganized, having a hard time tracking those long-term assignments, and might be engaging in some more risky and impulsive behaviors. And in more than 3/4 of the cases, these symptoms continue into adulthood. So we have a ton of research really showing that untreated ADHD and disruptive behavior disorders can lead to pretty significant lifelong impairments. For kids diagnosed with ADHD, in regards to school and academics, we know about 45% of kids diagnosed with ADHD have at least one or more significant impairment in reading, math, or spelling. Teachers report that these are the kids who are more often off task, are completing less work, might be more disruptive in the classroom, and are at a higher risk for school expulsion, dropout, and academic underperformance. family functioning. This is something that we're talking a lot about in treatment, but kids with ADHD have impairments in family functioning that both sort of impact and are impacted by the child. There tends to be more negative parenting practices, more frequent and sort of severe, maybe parental stress and discord, and also has implications for other members of the family. So siblings of kids with ADHD often reported feeling sort of victimized by their siblings, endorsed higher, levels of anxiety, and really sort of described their home life as chaotic, conflictual, and exhausting. The next sort of area of impairment can be the interpersonal functioning. This is something that we focus a lot on in treatment because we know that not all kids with ADHD have challenges with their peers, but disturbances in peer relationships is a really good sort of like predictor and mediator for some of those adverse adult outcomes. These are kids who might be labeled as sort of bossy in their play, immature, or just less aware of social cues and might act more impulsively, so might be more aggressive when they're upset. Long-term outcomes, again, when ADHD and these disruptive behavior disorders are not treated, the trajectory is pretty devastating, with outcomes of academic and vocational failure, much lower levels of organization, higher rates of self-injury, and involvement with the criminal justice system. So if any of sort of like the above feels or sort of like hitting home for you, or you're like, that really sounds like my kid, or we're really having those challenges, right? The next sort of step is to get an assessment. Unfortunately, there is sort of no single test to diagnose ADHD. We recommend really starting with the pediatrician to make sure you're ruling out any medical concerns. Oftentimes, pediatricians are the first people who are flagging some of those attentional challenges, or the first people that caregivers are talking to during those sort of annual visits. Once all the medical concerns are ruled out for both ADHD and ODD, a thorough review of the symptoms, of the child's history is really, really important. And we want to be getting data from multiple sources. It's really important in the process or when assessing for ADHD or other childhood mental health disorders that you're doing a really thorough diagnostic that assesses for all of the challenges that can be present for kids. This is because many things can present like ADHD or ODD, things like anxiety, trauma, depression, learning disabilities. So you would really need a trained assessor to be able to sort of effectively differentiate between the causes and provide an accurate diagnosis, which informs evidence-based treatment recommendations. So unlike ODD, the symptoms of ADHD must be present in multiple settings to qualify for a diagnosis, and a really thorough assessment of the ADHD symptoms from, again, school, other areas of kids' lives is really important. Oftentimes, this is completed through a semi-structured interview where we're talking with the child, or we're talking with the caregivers, maybe together or separately or both. And includes a set of standardized, validated questionnaires from, again, at least 2 sources. Oftentimes, we're getting reports from school, from parents, any extracurricular activities that your kids are participating in. Lastly, sort of ideally, to confirm an ADHD diagnosis, we would want a neuropsychological evaluation, which also includes a semi-structured interview and questionnaires. But what the neuropsych sort of provide is testing and activities to sort of measure how kids' brains work, their attention span, and sort of how they approach problems. And again, a thorough assessment of ADHD is really important, and ODD to inform those treatment recommendations. The 2 most common modalities for treatment in ADHD are those behavioral therapies, behavioral interventions, and medications. These have been studied for decades, sort of separately and in combination. What we found is that the gold standard approach to treating ADHD in kids is oftentimes a combination of medication and behavioral intervention, but those recommendations vary sort of based on the age of the kid. Like I talked about sort of in the beginning with Dr. Pelham doing a lot of the research with sequencing studies, what those studies really showed us is that the most effective approach to treatment is starting with the behavioral treatment and then adding medication if needed. Right? And that the worst or, the worst sort of outcomes began with medication and then added that behavioral treatment, which has been supported in many studies sort of moving forward. As far as sort of the age range for kids younger than 6 years old, the American Academy of Pediatrics recommends the behavioral parent training that Leah will be talking about in a little bit, as well as classroom interventions. And then for kids 6 to 18, those same recommendations, but as kids get older, their brain is more developed, they're more able to participate in treatment. And so, behavioral parent training and classroom interventions are very important, but we might also be adding peer interventions or things like organizational skills training and medication. Right? Not saying medication can't be used in kids younger than 6, but again, you would want to get a sort of full assessment of that first. When we're engaging in evidence-based treatment, we always want to be sort of monitoring treatment throughout. At our center, we actually have caregivers completing surveys every single week to make sure we're addressing those areas that caregivers are most concerned about. I'm now going to turn it over to Leah, who's going to talk about behavioral therapies for ADHD and ODD.
Thanks, Steph. Yeah, I'm seeing a lot of questions in the chat about what treatments are available for ADHD and ODD. And the good news is that there are a lot of really great evidence-based treatments available for these challenges. Just like Steph mentioned, sometimes, especially younger kids with ADHD or ODD can be difficult to treat in traditional psychotherapy. So research really shows that, parent-driven interventions or those interventions delivered in natural settings, like with peers in the classroom, are the most effective. Steph said at the beginning of our talk today, all of these treatments that I'll talk about are offered through the Baker Center. So if you're interested in receiving treatment, you can reach out to us. But the first treatment that I'll talk about is parent-child interaction therapy, which is an evidence-based approach for young children with behavioral problems age 2 to 7. Something that's unique about PCIT is that it's conducted through coaching sessions where the caregivers and the child are playing together while a therapist is watching either through a one-way mirror or virtually on Zoom, and then providing coaching to the caregivers through like an AirPod or a bug in the ear device on skills that the caregivers are learning to manage their child's behavior. PCIT first focuses, it takes place in 2 phases. It first focuses on establishing warmth in the parent-child relationship through a lot of these positive skills that I'll talk about later. And then the second phase of treatment really moves on to teach parents strategies to manage the more challenging behaviors. So caregivers learn strategies to help their child accept limits, comply with directions, respect house rules, and how to demonstrate those appropriate behaviors in public. Moving on to talking about behavioral parent training, or BPT. This is an approach that uses a lot of the same techniques as parent-child interaction therapy, but they're really aged up for kids that are older than 7. And unlike PCIT, it focuses on working with parents directly without the child present to learn those strategies that increase appropriate behavior and decrease non-compliant behavior. Then caregivers implement those strategies at home or in other environments that the kid might be present in. Like PCIT, behavioral parent training also focuses on increasing the frequency and potency of positive parent-child interactions first, and then moves towards, clear limit settings, setting consistent expectations, and creating a system of rewards and consequences. BPT also often includes collaboration with the schools to set goals and reinforce appropriate classroom behavior. The summer treatment program that Steph has talked about a few times is an evidence-based approach for kids age 6 to 12 with a primary diagnosis of ADHD. And the STP that we hold here at the Baker Center is called Camp Baker. Steph and I could both talk about Camp Baker for hours, but I will be brief in my description. It's a 6-week day camp where kids participate in typical summer camp activities like swimming, sports, and art. And while they're participating in those activities, we have an intervention kind of supporting them throughout. That intervention is in the form of what's called a token economy. So kids are earning points for positive pro-social behaviors like compliance, helping peers, contributing to group discussions. And then they might lose points for behaviors that we want to decrease that are common in kids with ADHD and behavioral challenges like complaining, non-compliance, stuff like that. They then use those points to meet individualized goals and cash in for prizes, which is really fun for kids. At Camp Baker, kids also engage in one period of academics to help reduce that academic regression that's really common in neurodiverse kids over the summer. We also focus a lot on social skills. So each day kids are taught a different social skill, and then counselors help kids implement those with their peers, which really helps them generalize those social skills to other settings. And finally, we hold weekly parent training sessions at Camp Baker. So parents are taught a lot of the skills that are covered in behavioral parent training to really help support all the skills that the kids are learning at camp and, generalizing those to home as well. And the last treatment I'll discuss here is called organizational skills training. And this is, really one that we use that we bring kids into treatment for. And it's an evidence-based treatment program for kids with ADHD to help address problems in organization, time management, and planning, particularly for schoolwork and those associated home activities like doing homework or getting ready for school on time. And through this approach, kids learn tools to improve their ability to track assignments, manage school materials, improve time management, and plan and organize their tasks. And while we do bring kids in for OST, just like all of the other treatments that I mentioned, parent training is really, really helpful, and parent involvement is, used as well in organizational skills training. So parents are involved in every single session, and they learn some of those behavior management techniques to incentivize kids to to use the organizational skills that they learn. There's also an opportunity in OST for teacher involvement to best support kids in developing these organizational skills. So I'll jump forward now to talking about some of the things that you can start implementing at home today. So the first one that we'll talk about is special time. And like I mentioned, the first phase of both behavioral parent training and parent-child interaction therapy is really focused on helping build a positive, healthy, warm relationship with your child. And the primary way that we do this is through special time. So special time is 5 to 10 minutes of uninterrupted, positive play with one caregiver and one child each day, participating in an activity that your kid likes doing. We think of special time as sort of like an espresso dose of positive attention to really fill the bank with positive interactions so that when you need to set limits or provide consequences later on, you're not really going into the red, which increases the likelihood that kids are going to comply when you're asking them to do things when their bank is full. To make special time as positive as possible, there are certain skills that we focus on caregivers using, and these are called our pride skills. So the first one is praise, and praise is really important. So I'll talk more extensively about it in a minute, but essentially praise increases the likelihood of positive interactions and positive behavior in special time. So throughout those 5 to 10 minutes, you should be praising frequently and being really specific about what it is that your child is earning praise for. So saying things like, I love how calmly you're playing. Our next pride skill is reflect, and this essentially means repeating back or paraphrasing your child's appropriate speech. So if during special time they say something to you like, I love playing with this castle, you might say something back like, yeah, this is a fun castle to play with. Reflecting shows that we are really interested in what our kids are saying, and it really allows them to lead the conversation. We want special time to be child-led, and reflection is one way that we do that. The next one is pretty straightforward. It's imitate. This basically means you're participating in, you're copying your child's appropriate play. Imitation is the biggest form of flattery. So if they are on the floor building a tower out of Legos, you are also on the floor building a tower out of Legos with them. Our next pride skill is describe, and we sort of call this our sportscaster skill. When you're describing, you are saying exactly what it is your child is doing. So you may be saying something like, you're making a tall castle, or you're dribbling the soccer ball down the field. Just like our other pride skills, this shows that you are really, really engaged in your child's play. Behavior descriptions are also really helpful for kids with ADHD who might be moving faster or a bit more inattentive, because it can really draw their attention to the task better and help organize their thoughts better about what they're doing. And our last pride skill is the most fun one. It is enjoy. With your facial expressions, body language, and what you're saying, you really want to be showing and telling kids that you enjoy spending this time with them. Special time is very aptly named. It will feel really, really special for your kids to have this time set aside for them each day. So, like I said, praise is really, really important. I already mentioned it briefly in the context of special time, but we always, spend more time thinking about praise outside of the context of special time as well. We know that behavior that is rewarded through attention and rewarded through praise is more likely to happen again. So we want to be pointing out all of the great things that your kid is doing throughout the day. And I will say, I know that all of the caregivers in the room do provide praise to your kids, and there are particular qualities that we want praise to have to make it as effective as possible in motivating behavior change. The first quality that I mentioned briefly is that we want it to be specific and labeled. So if I say good job to a kid, that's going to feel really good. And realistically, they have no idea what to do to earn that praise from me again. Whereas if I say, really nice job playing so calmly with your brother, they know exactly what to do to earn my attention again. So we always want our praises to be really specific and labeled. Next, we want praise to be positive. And what this means is that we are labeling the behaviors that we're seeing rather than the absence of misbehavior. So if you're used to your kid complaining, rather than saying, thanks for not whining, we're going to say something like, thanks for speaking to me with an appropriate tone of voice. The next one is immediate. This one's pretty straightforward. Praise works best when it's delivered as quickly after a behavior as possible. That really helps kids link the good feeling that they get with the behavior that they did. And last, we want praise to be really frequent. This is the name of the game. Make things as positive as you can when kids are, doing great things. We don't want to wait for that extraordinary behavior before offering praise. We really want to meet kids where they're at and offer praise and positive attention for all the great things that they're able to do now. When we're offering praise really frequently, behaviors improve and you slowly but surely get to those extraordinary behaviors that you were hoping for. So hand in hand with praise comes selective attention. So just like positive behaviors can be made to happen more often by giving them attention, behaviors can also be lessened in strength or frequency by removing our attention from them. So I'm sure a lot of the caregivers in the room would be able to identify at least a couple behaviors that your kids do to get attention, probably those negative attention-seeking behaviors. So if a child engages in one of those behaviors and we do not offer them reinforcement for it through our attention, the behavior will begin to happen less often. I will say that we use selective attention for behaviors that we consider disruptive or annoying, but not for behaviors that are dangerous or clearly rule-breaking. So good behaviors to use selective attention for are things like complaining, talking back, cursing, general fussiness, stuff like that. So when you notice one of these behaviors occurring, rather than asking the child to stop or scolding them, you're actually just going to ignore it. And it may help for you. I know some of these behaviors are incredibly frustrating, so it may help for you to turn away, get involved in another activity, or provide praise to a sibling or another child that's behaving appropriately. I also will say that when you withdraw your attention and kids are used to getting your attention, they may try harder and really up the ante to get your attention back. But it's really important that you sort of ride that wave and keep ignoring that behavior for as long as it's happening. One of the most important parts of selective attention, though, is that you re-engage and you provide that praise as soon as the behavior stops. So if your kid is yelling, they are complaining, they are doing whatever, we're ignoring until they quiet down. And then as soon as they're quiet, you're immediately jumping back in with a labeled praise, like, thank you for using your inside voice when you speak to me, or whatever the opposite of the behavior is that you were ignoring. Over time, with our skill of selective attention, kids learn that they do not earn our attention when they're being demanding. And then through our labeled praises at the end, we are teaching them the right ways to request or to earn our attention. So the last thing that I'll cover are some strategies that help our kids that have a harder time with organization and materials that are really, really common parts of ADHD. So the first thing that we really recommend are checklists. I have a couple examples here, but you can use checklists for any and everything that you can think of. The first one that we recommend are backpack checklists. I'm sure a lot of our caregivers of children with ADHD have had the experience where your kid is ready to get started on homework and they find that they've left half of their materials at school, or they get to school and, figure out they've left their lunch at home or they forgot their homework at home. So we encourage the use of backpack checklists to help kids keep track of all of their materials that they need to bring to and from school and home. These checklists can and should be attached to their backpack so they really can't miss it when they're packing up their things. And they may need some support with this. So you're helping them with their backpack checks at home. And this is also a really good opportunity to get teachers involved as well, especially for younger kiddos, so that teachers can help them complete their backpack checks at school. The next checklist are workspace checklists. And this is, when kids are sitting down getting ready to do homework. They often think that they have all of their materials ready. They get started on their homework assignment and halfway through realize, oh, I need a ruler or I need scissors or I forgot this other material that I need to get. When they get up to go get that material, that's when they get distracted. And then it's really hard for them to re-engage in that task. So by having a workspace checklist where you're making kids kind of sit down, think through all of the materials that they need to complete their homework, that helps prevent some of those interruptions and helps them sustain their attention to their homework. Moving on to visual schedules, I think a lot of times we like to assume that kids know what steps to complete in their morning routine, for example, but we find that kids continue to have difficulty completing all of the steps on their own. Kids with ADHD, we've talked about, have a hard time with time management, knowing how long a task is going to take, organizing all their materials for a task, and then when they're finally starting the task, really sustaining their attention to it. And that's a lot of executive functioning, organizational, skills that are already hard for them. So by having a visual schedule, it really helps to download some of that. So they're not having to remember all of the steps of their morning routine on top of doing all of the planning for it. So it, eases up that cognitive load for them. The other thing that's really helpful about visual schedules is that it's when we have it written down and printed out, it's more likely that these routines are going to remain consistent. And routines and consistency is really the name of the game for helping kids with ADHD be successful. So not only does it make it so that they don't need to remember all of the steps, but it's more likely that their routine is not going to change, which makes it, more likely that they're going to remember all the things that they need to do. And then finally, moving on to planners, encouraging kids to use a planner really increases the likelihood that they're going to remember their homework assignments and be able to organize the steps around completing longer term projects. Keep in mind that you will likely need to be creative with your kid to help them find a system that works to track both daily and longer term assignments. And kids likely need a good amount of support with this. I'm sure a lot of you have encouraged your kids to use planners before with probably, variable success. So caregivers should be checking each day to see if the planner is filled out and cross-reference with any, materials or information that the school provides. I know a lot of schools will post homework on Google Classroom. So you can be checking your kids' planner each day, making sure that they've written things down correctly. This is also another really good time to get caregivers involved, to get teachers involved. So you can ask the teacher to provide support by reminding your kid when it's time to write down homework, or, at the end of the day, having a teacher or another trusted adult at school checking kids' planners to make sure that everything is written down correctly. Like I said, I'm sure a lot of you have tried using these things before, and kids with ADHD might not have a lot of motivation to engage in these tasks. So this is when it's really helpful to use some of the other positive reinforcement strategies that we've talked about, like praise, or even tangible rewards to, incentivize kids to use their planner or complete their backpack check or complete their homework check. That's going to be really helpful in increasing that motivation and helping them to be successful.
Awesome. Thanks, Leah, for talking about the skills that you guys can start implementing right away. Here is our contact information for the Baker Center. So all of those skills that Leah talked about, if you think you need sort of more individualized support, that is where you can sort of maybe schedule a phone screen. Caroline has included this on the website, so bakercenter.org, and it really sort of talks about what our evaluation process looks like. Along with this seminar series, there are sort of blog posts, social media, posts related to this talk. And so we just added our Instagram, YouTube, and Twitter handle, I think it's what it's called, handle for you all. Yes, thank you, Caroline. Handle for you all to follow for those additional resources around ADHD disruptive behaviors and all of our educational series that we've talked about, which has been depression and then school refusal. So now we'll really open it up to questions for you all. Oops, that you all have. I'll start in the chat. I'm just going to work my way down. It's hard to manage both. Let's see. So somebody asked sort of regarding friendships, what the connection is between fewer friendships and ADHD. We know, again, that the interpersonal sort of functioning are really common for kids with ADHD. Oftentimes due to their maybe impulsivity, the difficulty resolving conflicts, that lack of social awareness, that some of our kids diagnosed with ADHD do have, fewer friendships, a greater sort of association maybe with peers who are engaging in more negative behaviors. They may have more frequent peer rejection, and kids with ADHD are actually more at risk of being a bully and being bullied in schools or extracurriculars or sort of in their lives. And so because of the impact of just peer relationships, that social support, we know it's one of the sort of best predictors and mediators for adverse adult outcomes that we talked about, those long-term impacts. And so it should really be a focus of like the assessment and intervention when thinking about the kids with peer challenges. I see another person asked about medication and therapy. I think we answered that question. I see another question, what positives can parents look forward to? Characteristics of ADHD and autism don't resolve. Is it coping mechanisms, just getting better, or building that self-awareness? That's a really good question. Maria, really happy to see you here today. But like Leah said, we're going to start with all of those positive parenting strategies. That doesn't necessarily mean we're going to change like the structure of the brain, but what we're teaching caregivers in these parent training interventions is also ways that we're helping kids with that emotion regulation. A lot of the skills that we are teaching caregivers is going to help kids better manage those symptoms of ADHD and the behavioral challenges, including autism. Right, that treatment looks a little bit different. So please, make sure you're doing your due diligence around that. But it's not necessarily something that goes away. We're just teaching them different skills to manage how their brain works. We sort of describe it as like your brain is, or, ADHD brains are different. And that actually can be like your superpower, right? We just got to figure out how we can best sort of help you manage those things. Another question around the overlap of ADHD and autism. What is the comorbidity or sort of overlap? How do you know which diagnosis is leading a particular behavior? Does it matter? Are the treatment strategies treatment the same regardless? Really good question. There is a very significant sort of overlap between ADHD and autism. I think at our sort of summer program, we had about 30% of kids also had that comorbid diagnoses. Doesn't matter what's underneath. So yes, you would need like a full neuropsych assessment or evaluation if you are concerned about ADHD and autism. Those are both neurodevelopmental disorders. We are talking primarily about ADHD here. We see kids who do have an autism diagnosis and also maybe comorbid challenges with anxiety, depression, behavioral strategies. And we know these are the strategies that we're teaching caregivers are really broad behavioral principles that really work for everybody. We use them at our clinic. We all sort of talk to each other in the same way. It's kind of funny. But again, these are basic sort of behavioral principles that we know sort of work with kids and adults, even if they might have a diagnosis of autism as well. The treatments might be a little bit different depending on the level of severity of autism. So I would sort of going to defer that to the autism specialist, but I would make sure to sort of do that research. But the gold standard approach to assessment for both ADHD and autism is a full neuropsychological evaluation. Are there any behavioral therapies for ADHD that worked instead of medication? I think we answered that question already. Leah did a great job sort of explaining all those behavioral treatments. Let's see, Maria. Oh, that's a really good question. Unfortunately, I do not know the Baltimore sort of area, but I do know Kennedy Krieger does have the behavioral management clinic that might provide some of those evidence-based therapies that we're talking about. Hope Mark is doing really well, and it's great to see you, Maria. Next question, can selective attention be used with teenagers, and is it effective? Leah, do you want to answer that question? I've been talking for a long time now.
I sure can. Yeah, selective attention can certainly be used with teenagers. And something that I like to mention, I know a lot of families that I've worked with were parents of teenagers rather than younger kids, they want to teach their kids why it's wrong to do the things that they're doing. And so something that I think is really important when we're thinking about selective attention for, particularly older kids is we're ignoring it in the moment. And it doesn't mean that you can't ever talk about those behaviors, but we just want to be really careful to not give attention to the behaviors in the moment because that can end up being reinforcing. I also suspect that these, behaviors like arguing or cursing, a lot of kids do know that they're not supposed to do them. So ignoring them in the moment or using our selective attention will, help prevent reinforcing those behaviors. And you can have, conversations about it later. But all of these strategies, praise, selective attention, they're basic behavioral principles that really work across the, lifespan. And the next question that I see here is, can visual schedules be used with children with autism? And the answer is undoubtedly yes. Visual schedules can be used for anybody. We all use visual schedules at some point. I think if you are ever noticing your kid having a harder time like completing tasks or knowing what's coming next, visual schedules can always be really, really helpful with helping them, complete all the things that we are expecting of them. Our next question here, okay, I can take it. For dangerous or rule-breaking behavior, what do we choose instead of selective attention? So we come up with a system of consequences when we work with families in outpatient treatment or, in PCIT or teaching, caregivers of kids at Camp Baker. We use, a sort of like a longer, more structured active ignore. I don't want to give too much information about it because we need to have all of the other strategies in place first before we're really jumping towards consequences. I think a lot of times that's the first thing that people can tend to jump to when you're seeing those dangerous or rule-breaking behaviors. And we know that consequences don't work as well when we don't have all the positive stuff in place. So if that's something that you're seeing a whole lot, I'd recommend reaching out for, an assessment and getting into more individualized treatment so that you can, receive the support that we know is really, really helpful for those more dangerous or rule-breaking behaviors.
Does ADHD affect more males than females? It affects more males. The inattentive presentation is more common in females diagnosed with ADHD, but just the general sort of prevalence is more for males than females. Discussion around ODD, whether it should be a diagnosis at all, how it's often used overused as a label for kids who've actually experienced trauma. There's a lot of stigma around the label for ODD in foster care, and what are our thoughts are over labeling. That is such a good question. Thank you so much for bringing that up because it is something that we talk about a lot in our clinic, a lot about with our families for actually both ADHD and ODD. Both of those, ADHD in particular, can be extremely sort of overdiagnosed and something that providers sort of like jump to. It's like, oh, problem behavior, it must be ADHD. And that is not necessarily the case, which is why we do suggest a really thorough review of those symptoms, the history, what's going on with the kid, because you're absolutely right. Temper tantrums, difficulties with attention, those sort of like hallmark features of ADHD and ODD are certainly symptoms of trauma as well. And so that's why we're saying a really thorough assessment is so important, because what we would recommend for treatment recommendations is going to be different if it's trauma-based versus if it's, ADHD or oppositional defiant disorder. When we are giving the oppositional defiant disorder diagnoses, we really say we use that diagnosis, or sort of the DSM, which is the manual for diagnoses. The reason that it's important is because a lot of the evidence-based treatments are informed by diagnoses. And so we say, yes, we are giving this diagnosis because they meet criteria, and right, it belongs to you. We are not telling schools, we're not telling other people. It might not even be relevant to tell schools if the behaviors are only happening at home. But thank you for bringing that up, because that's incredibly important to think about. And that's actually part of, a big grant that we received that's allowing us to do these educational series. Part of what we are also doing is providing that psychoeducation to schools, to pediatricians' offices for that exact reason. So thank you for bringing that up. Where can I learn more about the summer treatment program? So we have our own summer treatment program here. It's called Camp Baker. If you go on the Baker Center website, under programs, there should be a Camp Baker tab, which will tell you more about our program, which Leah and I are obsessed with, and we could, again, talk about all day. At what age is ADHD diagnosed? Also a really good question. ADHD, the symptoms must be present before the age of 12. But as you probably could hear by how sort of Leah and I described the symptoms of ADHD, those are just really common behaviors in young kids, right? Little kids have a shorter attention span. They're hyperactive. They're running around. They might have a hard time. Thank you, Alex, for adding that. They may have a hard time following directions. And so at our clinic, at our center, we do not diagnose earlier than age 6. One of the reasons for that is, again, we want to be really thorough when we're giving an ADHD diagnosis, because it is a neurodevelopmental disorder. And oftentimes prior to 6, kids might be in less structured environments. So once kids are in a structured sort of school environment, that's oftentimes when we're seeing, oh, this kid might have, hyperactivity sort of above and beyond the other kids in the class, or their same aged peers. Right? But it can be diagnosed at, sort of any time. Any other sort of final questions before we end for today?